Good afternoon. First of all, I'd like to thank Professor Abdullah Shihab and Professor Giuseppe Rosano for the kind invitation to participate in this important meeting. And in a couple of minutes, I'm going to cover coronary artery disease and heart failure risk strategy and outcomes. This is my disclosure. We know that ischemic heart disease is the most common cause of heart failure. It represents two-thirds of cases of heart failure. Mainly, it is due to coronary artery disease. Routine revascularization provides superior outcomes compared with optimal medical treatment. Management of patients with chronic heart failure and concomitant coronary artery disease is challenging in the daily clinical practice. However, the current European and American guidelines recommend an invasive approach in addition to optimal medical treatment in patients with HFrEF and multi-vessel coronary artery disease. This slide from the EC Heart Failure Long-Term Registry published 2017, and we can appreciate that ischemic heart disease represents around 43% of all cases. And if we look for HFrEF with an ejection fraction less than 40%, 49% have an ischemic etiology. PCI was performed in 29% of those patients, and the coronary revascularization with cappage in 15%. So coronary artery disease is the main cause of heart failure in the EC registry. And we know that heart failure in coronary artery disease patients, we have different phenomena can be seen in the form of myocardial stunning, which it is transient LV systolic dysfunction after ischemia for a short time followed by revascularization. In such cases, the contractile reserve is preserved as well as glucose metabolism. Extracellular volume is normal or mildly elevated, and the recovery is 100%, and usually it takes days to recovery of LV systolic function. On the other hand, downregulation of the myocardial function, which is known as hyperrenating myocardium, due to chronic reduction in coronary blood flow, is associated with hyperrenating myocardium. And the contractile reserve also is preserved, as well as glucose metabolism. Extracellular volume is moderately increased, and the recovery after revascularization takes weeks or months in advanced hypertension. But in patients who develop myocardial infarction, the contractile reserve is lost due to development of myocardial fibrosis, scar, no glucose metabolism, and the recovery is minimal or absent. So this interesting slide shows the changes in normal as well as hyperrenating myocardium. You can appreciate on the left, the upper panel. This is a light micrograph of a myocardium, which showing normal cardiomyocytes with no glycogen. And on the right, this is a transmission electron micrograph with a normal cardiac myocytes. But on the lower panel on the left, this is a light micrograph of a biopsy sample of human hyperrenating myocardium. And here, the cardiac myocytes are depleted of their contractile material and filled with glycogen. And on the right, this is transmission electron micrograph of a hyperrenating cardiomyocytes, and the myolytic cytoplasm is devoid of sarcomers and filled with glycogen. So the dilemma of management of patients with heart failure and coronary artery disease, whether to revascularize or to medically treat those patients only, and revascularization either PCI or cappage. The rationale for revascularization in patients with ischemic cardiomyopathy is based on increase in the ejection fraction due to relieving the myocardial hypertension. This also will be associated with prevention of lethal ventricular arrhythmias. On the other hand, decreasing inducible ischemia and repetitive stunning will decrease ventricular remodeling, decrease diastolic dysfunction, and this will improve symptoms of heart failure. And finally, revascularization will decrease the probability of spontaneous myocardial infarction. And to detect whether the myocardium is viable or not, we have to do some imaging tools which can identify which patients is ideal candidate for revascularization. So in the daily practice, we can use stress echo, and in stress echo, the myocardial viability defined as a change in the wall motion score index for at least 2 segments within a coronary territory. The sensitivity of stress echo is around 80%. Myocardial perfusion imaging with the SPECT, also the viability definition is a change in the uptake of myocardial perfusion radiotracers using thallium or technetium-99 with a sensitivity up to 87%, while positron emission tomography or PET have a higher sensitivity of 92% based on the change in the proportion of myocardial tissue with low perfusion and the higher glucose avidity. And CMR now is considered as a gold standard, either with the drug like dobutamine or not, and with the myocardial viability defined as with several features, including the preserving a contractile reserve or not, lead gadolinium enhancement, myocardial perfusion, and the sensitivity of CMR is high compared with stress echo, SPECT, and PET with the 95% sensitivity. So this is an interesting slide which showing the management of ischemic cardiomyopathy compared with non-ischemic cardiomyopathy. And in ischemic cardiomyopathy, we have different phenotypes based on the presence or absence of ischemia, viability driven or not. The dominant substrate is different. So a phenotype of ischemia, viability driven, this is based on the presence of obstructive coronary artery disease, matching dysfunctional territories, the presence of viable myocardium or contractile reserve, and limited transmural scar. So those patients have a potentially reversible ischemic myocardium, and revascularization, in addition to guideline-directed medical therapy, are considered the therapeutic management strategy for those patients. Other patients have a scar-dominant post-MI remodeling. They develop previous myocardial infarction with a replacement fibrosis, adverse remodeling, and the clinical interpretation is based on LV dysfunction, mainly reflecting irreversible myocardial fibrosis and remodeling, in addition to GDMT therapy and device therapy when indicated, secondary prevention, and the arrhythmic risk stratification, advanced heart failure management, and revascularization only if symptoms or residual ischemia are present. The mixed phenotype of ischemia and myopathic ventricle also, this is a multifactorial LV dysfunction, relative contribution of coronary artery disease is uncertain, and this is based on coronary artery disease plus non-ischemic myocardial disease. So guideline-directed medical therapy is the main treatment strategy. Non-ischemic cardiomyopathy is totally different. So for many years, we have evidence from previous studies which indicated that revascularization in patients with multivessel disease with an ejection fraction lower, especially if it's less than 35%, the outcome in terms of 10-year mortality rate is much lower with revascularization compared with medical treatment alone. And the management of HFrEF in patients with coronary artery disease, guideline-directed medical therapy using the 4 pillars are mandatory to decrease mortality, decrease heart failure, hospitalization, and in the presence of coronary artery disease, revascularization with PCI or CABG according to the guidelines. For many years also, we have evidence from the landmark trial, which is STITCH trial, surgical treatment of ischemic heart failure, when 1,200 patients were randomized to CABG and optimal medical treatment compared with medical treatment alone in patients who have an ejection fraction lower, the median ejection fraction was 28%, with a multivessel disease. And the primary endpoint in terms of all-cause mortality, probability of death from cardiovascular causes, was not statistically significantly different between surgery and optimal medical treatment. However, probability of death from any cause or hospitalization for cardiovascular causes was significantly lower with surgery compared with medical treatment. But the long-term follow-up of STITCH trial revealed that a median of 9.8 years follow-up, the outcome with surgery was much better compared with medical therapy regarding survival. So the short-term outcome for STITCH was not good. Mortality was high, but the long-term outcome was good in terms of lower mortality. Revascularization by PCI was studied in REVIVE, and in patients with lower ejection fraction, 700 patients were randomized to PCI versus optimal medical therapy in the presence of viable myocardium. And in this trial, there was no significant difference between PCI and medical treatment regarding the all-cause mortality. Sub-study from ischemia trial proved that patients who have history of heart failure or lower ejection fraction below 40%, the outcome of primary endpoint was much lower in patients who were subjected to revascularization. So the guidelines for myocardial revascularization recommend revascularization in patients with LV systolic dysfunction and coronary artery disease suitable for intervention. This is class 1B. CABG is the first revascularization strategy in those patients, which is class 1B. PCI is considered 2A. In patients with three-vessel disease and LV systolic dysfunction, heart team approach is mandatory. So in the presence of angina, class 2A to consider revascularization, and also revascularization is recommended to improve outcomes when coronary anatomy is suitable for revascularization. This is class 2B. The first choice revascularization strategy is bypass surgery. PCI is class 2B, while surgery is class 2A recommendation. So this is very interesting algorithm that patients who have chronic ischemic LV systolic dysfunction who are suitable for revascularization should be subjected to imaging tool to identify evidence of ischemia or not. If yes, and the extent of scar on CMR less than 25%, this is an indication for revascularization and optimal medical treatment. While in the absence of ischemia and scar more than 50%, optimal medical treatment alone is recommended. And this slide summarizes the different management approaches for patients with heart failure and coronary artery disease. GDMT decrease mortality and hospitalization. Revascularization in STITCH trial decrease all-cause mortality in the long term. Transcatheter edge-to-edge repair for mitral valve was associated with reduction of hospitalization but not mortality. ICD for prevention of sudden death. Heart team approach and considering comorbidities, anatomy are recommended in addition to informed consent, patient-centered care, shared decision-making before subjecting those patients to revascularization. And nowadays, STITCH 3 trial is ongoing to compare PCI or CABG, and Cairo University is a center for included in this multi-center trial for STITCH 3 trial. And this is my team at Cairo University involved in STITCH 3 trial. So the take-home message, ladies and gentlemen, ischemic heart disease is the most common cause of heart failure. It carries a worse prognosis and the management is challenging. Guideline-directed medical therapy and device therapy remain the cornerstone of treatment. Surgical revascularization offers the potential for improved survival and quality of life, particularly in young patients, good functional capacity, three-vessel disease, and the heavily remodeled LV. PCI does not improve prognosis in stable patients, and its use should be restricted to treatment of angina and acute coronary syndromes. Finally, revascularization in severe ischemic LV dysfunction should be individualized and to be based on a heart team discussion. With this, I finished my presentation. Thank you for your attention.